who is director at the Institute of Neurosciences, Kolkata.
So back again now from brain to bowel. It's a pretty big jump from the top floor to the basement. Now, just a background on the bowel management. I'm sure a lot of the senior physiatrists and few of the students might have come across a number of spinal cord injury patients and patients with bowel problems. I'm sure initially it's always, doctor, when will I be able to walk? And then once it sinks in that they might be able to walk, they might not be able to walk, whatever the reason, whatever the outcome is. But I think at the end of the day, what really matters is their bladder and bowel. But more than the bladder, I think it's the bowel, because at the end of the day, release definitely makes everyone happy. So now getting into the topic, there are a number of reasons, but for us the main cause would be spinal cord injury. We also have multiple sclerosis, spina bifida, strokes, and even Parkinson's for that matter of fact. Even pediatric patients have a lot of issues with their bowel movements if they are neurologically affected. So consequences, it's either constipation or incontinence, and at the end of the day again it's the poor quality of life. Now pathophysiology, either it can be an upper motor neuron bowel which is hyperreflexic, it can be a element bowel which is areflexic, disruption of both voluntary and reflex control, and it could be an altered colonic motility and sphincter issues. Now if it is around the conus region, you might have a mixed picture of both hyperreflexia as well as areflexia as well. Now what are the features? As I have mentioned, constipation, fecal incontinence is something which is the outcome, but probably the most disturbing symptoms are bloating, your discomfort, that is, and for SCI patients T6 and above, these can actually lead to serious complications like autonomic dysreflexia as well. So just in a nutshell, UMN, LMN, its constipation is frequent in UMN lesions. In LMN lesions it is severe and it is prolonged. Incontinence could be reflex emptying for UMN patients and flaccid sphincter in lower motor neuron patients. Evacuation techniques for UMN bowel, its digital stimulation is effective, and LMN, as we all understand, it's most probably patients would need digital evacuation. Now, what are the goals of management? I think there are the slide speaks everything, but for me, and I think for every one of us, the most important would be a regular bowel routine, because that is something which we as a physiatrist would be guiding the patient towards. Bowel management is such a thing that it cannot happen overnight. We cannot be with the patient, so we cannot manage everything regarding the patient's bowel movements, but at least we can guide them through as to how and when they need to really manage their bowel and the program accordingly. At the end of the day, we can just be a guide, but the patient is probably the best teacher for their own bowel management routine. Now, conservative management, it could be dietary modifications, but again, high fiber, how much of high fiber diet do you need? Usually not more than 25 to 30 grams a day. Adequate fluids, because more more than the limit, it actually would lead to more of bloating and discomfort. We need adequate fluids for this fiber to work properly. How much? Again, 2.5 to 3.5 liters. But on the other hand, we need to take care of the bladder management as well. So we have to have a balance for patients who need to use that 1.5 to 2 liters of water for their bladder and 2.5 to 3.5 liters for the bowels. So these are things which the patient over time knows how to manage. Physical activity, very important. Scheduled toileting. This is probably the most important. Again, I am reiterating as I did it for the brain injury. The regular timing is the most important of this full bowel management program. Now, pharmacological managements. These are the points I can just run you through. But again, there are a number of poisons mentioned here. But we need to know the role of them. So for a stool softener, how does it work? It's just an easier transition. Laxatives, it increases the water content. Stimulant, mainly used for UMN lesions, it triggers the peristalsis. And perrectal agents, again, that's for local evacuation, mainly for LMN bowels. Now, what are the techniques? It's a digital rectal stimulation or DEDS, manual evacuation, suppository enema assisted evacuation, and again consistent scheduling or regular training of your bowel program. What are the approaches? This is a very interesting slide. Again, this is from the this x-axis is actually your lifestyle and conservative measures. So this is from Cochrane study, which shows lifestyle and conservative measures are actually 8 on a score of 10. If you go to digital and mechanical techniques, it is 7. Pharmacological comes down to 6. Surgical and advanced options, it's 4. But I'll discuss about this later on because that is a very important part of our bowel management as well. Now, just to make it a bit interesting, I thought I'll just run through a few patients of ours, like how we manage, and again, these are all evidence-based. Even if it is evidence-based, the onus actually lies on the patient to manage his or her bowel program. This is what we can just guide them through. So, 35-year-old male, complete T10, complete spinal cord injury. So, is this a UMN or a LMN bowel? Can anyone just raise up their hands? This is LMN or UMN bowel. जोर से UMN, fine. So, problems could be constipation. Why this occasional leakage? Any idea? There is a term, spurious diarrhea. So if you have mentioned about it, I'm sure you know about it. Can you just let your friends know what spurious diarrhea is all about? So it's basically constipation, and there is impacted stool, and you give more of softeners and everything, and it just trickles around the hard stool. Then you have these occasional leakage. So there was a trial of diet plus laxatives, but no routine was established. So concern was again for rehab, for people like us, we have to improve the independence. So for that person, there was loss of independence. So there we need to set a proper bowel planning. So these are actually guidelines. We cannot fix a proper thing through like, none of these lines are actually like a set program for each patient. Everyone has to be tailor-made over a period of time. So initially, it needs to be assessed properly. A proper history taking is very important, because we are not sure whether we are dealing with a spinal cord injured patient who has any comorbidities. If he is diabetic, automatically the transit time is prolonged. So more the prolonged transit time, more the constipation, and that might lead to your hemorrhoids, your pressure on the pudendal nerve, which might lead to pudendal neuropathies. So we need to do a proper assessment of the patient's health status and the medical status as well. Then we run through everything. Now oral agents, bowel program, regular toileting, rectal stimulation, because this is an UMN bowel, along with suppositories. Adjuncts can be used. If it is refractory, we can try transanal irrigation or neuromodulation or stoma. We can come to these later on. So second case, a 28-year-old female, history of spina bifida. So it will be an element bowel, severe constipation, tried laxatives, no effect. Shifted to manual evacuation and or transanal irrigation. So outcome, improved continence and independence. This doesn't mean that this program might work for other patients as well. So bowel programs, schedule the routine, rectal stimulation, suppository enema if needed, and at the end of the day we have to monitor and adjust the routine according to the patient's need. Busy slide. At the end of the day, whatever I have just mentioned, it's just written out here. So it's for constipation and fecal incontinence. So fecal incontinence, what actually happens? It's a element bladder, element bowel. There will be lack of anal tone, and we can use a bit of water soluble fibers just to make it a bit firm, and then we can use low volume rectal enemas. For constipation, as we discussed, we can run through the points, but at the end of the day, if everything fails, the only option would be to go for a diverting stoma. Now, let me tell you something. There is a basic difference between the Western culture and our culture. For us, this having a surgery for a bowel program is basically becomes like a taboo to have a colostomy bag but working in the Western culture, in the hospitals abroad, we have seen that patients themselves actually advocate for a stoma bag, because they know that at home there won't be many people around to help them out. So from the very initial days, there is a bit of bias towards counseling for diverting stomas, and to a large extent, if it was myself, I would have gone for a colostomy, because that actually brings improves the independence to a large extent. Now, case 3, multiple sclerosis, here it is alternating constipation and urgency because of the neural circuits involved, occasional incontinence. On oral laxatives, poor control, social withdrawal due to fear of accidents. Again, multiple sclerosis, you expect them to be mobile, independent with most of the things. But at the end of the day, it is a social inhibition. You just remain back home because you cannot go out unless and until your bowel movements are sorted out. So plan, again, a structured bowel program, osmotic laxatives, biofeedback. Now, biofeedback, do you have any idea what biofeedback is all about? Have you heard of biofeedback? Obviously, yes. So, any idea why biofeedback is might be used in bowel management? No answers. Okay, fine. So, here we have to understand why we need to use biofeedback, because there are muscles in your abdomen, your muscles in your perineum. So, if we make the patient understand the muscle movements required for your bowel movement and make them sit in front of a biofeedback machine or an EMG biofeedback machine, and we stick electrodes on the places that are needed, we can actually help the patient, if not completely, to have an idea through the biofeedback to improve their bowel management program. We actually have done a few run a few patients through this EMG biofeedback and seen that there has been a change in the patient's attitude, a change in the patient's bowel movement. I am not claiming that we have had 100% results for everyone, but there has been a change in their bowel program routine, and it's shown positive changes as well. So again, structured program, biofeedback, and at the end of the day, improved continence, confidence, and improved quality of life. Post-stroke, there could be constipation, fecal impaction, patient is confined to wheelchair. So plan would be post-meal toileting, stool softener, caregiver assisted stimulation if that is needed, and at the end of the day there are few impactions and smoother evacuation. Case 5, Parkinson's, 60-year-old male, severe constipation, bloating, incomplete evacuation, minimal benefit from diet. Sometimes it doesn't work, sometimes nothing works, or sometimes even a small tweak in your dietary habits might really help you. Now you have to think practically. If you are advising a patient a strict diet chart, it's not always possible. Sometimes you will feel to have something from Haldiram's, and that upsets your bowel completely. 3 days you are just like haywire. But that is the reason these patients have a strict bowel regime of their own. Even if you are their doctor, if you want to tweak something in terms of their bowel program, they will resist like fiercely, because they don't want any change of medicines, anything to be done by us. That happens over a period of time, because they get used to their own bowel regime. And if you are actually trying to tweak with their bowel regime, they will definitely switch over to a new doctor. That is for sure, because bowel management is something which these patients have over a period of time like individualized their own program. So not getting into these things. Case study, one more, Cauda equina, we all know, LMN bowel, areflexic, flaccid anal sphincter incontinence. So the best treatment for them would be digital evacuation, along with transanal irrigation, and if the patients cannot do it on their own, they can have a caregiver support as well. Outcome, improved hygiene, improved independence. So I'm not getting into all these slides. Case 7, for a kid, spastic, quadriplegic, chronic constipation, stool with withholding, painful evacuation. Now this is very important, because they are kids. If they have this experience of having a painful evacuation or a release, these kids will resist themselves from even sitting on the throne. That is the problem with the kids, and over a period of time they just develop the constipation, and it reaches to such an extent that it becomes an emergency. So and even with frequent enemas, things do not work out. So for the kids, it is really important that we work as a team and take them into confidence and give them the most recreational way of evacuation. So stool softeners, suppositories, massage might help, caregiver training, and obviously at the end of the day, it's a better kid along with a family quality of life, because the kid awake the whole night, I think it's very difficult for the family. So now let's just move into the advanced or the interventional options. There are transanal irrigations, there are sacral nerve stimulations, and the stoma bags. Now, so at the end of the day, whatever we do, we have to do it as a team. As a physiatrist, we just try our best to guide the patients to make their own bowel program. Physios will definitely help them through to improve their mobility, because mobility is such an important part of your bowel movement program, because the more you are mobile, it helps with your transition of your food. Now, occupational therapists, again, the more the function of the patients, better it will be the outcome in terms of the bowel program. And we cannot forget about these people, because in the Western world there are stoma specialists, there are nurses who actually are trained to handle only bowel programs. So as I mentioned, it's a multidisciplinary health team with the doctor who does the medical diagnosis, treatment planning, and the medical management, and the nursing specialists. They actually they are basically the nodal point of referral, and any program without a nursing staff is basically a failure. So we whatever we do, at the end of the day, if we do not educate the patient on what exactly has happened, what is happening, and what might happen, the full program is going to fall apart, because these patients need to know what exactly has happened with their system. Once they are aware, because if your mind doesn't know, your eyes doesn't see. So if these patients are made aware of their problems, of the nerves that have been damaged and the outcome that it can cause, I am sure to a large extent counseling actually helps with the bowel program as well. Their frustration comes down. The psychologists can be a part of this program as well. So if you can bring the patient into confidence, I am sure you actually have done a big job in helping them manage their own bowel. So an important slide which we probably more than us, the nursing staff need to be aware of this. Now, so before we come to the end of this presentation, I am sure we need to know what Cochrane has to say about bowel, the evidence for neurogenic bowel management. So this is about transanal irrigation. Cochrane says it reduces constipation, it reduces incontinence and fecal impaction. It definitely improves quality of life. What is the evidence? It's moderate, but the only thing is that it is limited by small RCTs. So transanal irrigation has moderate evidence in the management of bowel program. Do you all have any idea about what transanal irrigation is? Sorry? Soap water enema. So it's just to flush the bowel through the bottom passage so that whatever is inside can be flushed out. So it's just water. You can use soap, but water should be more than enough. It's usually 500 mils to a liter. So that can be practiced daily, alternate days, or at the minimum twice a week. Now, very important slide, because this is something which we need to know. It's of no use prescribing toxins like whenever we want to. So if you really look at the Cochrane evidence, limited Cochrane data, what we do, patient comes to you, it's a constipation, this and that, we just advise medicines indiscriminately. That actually plays up with the bowel more than if we hadn't introduced them to too much of medicines. We have to be very careful and judicious about prescribing any sort of oral and rectal medications. So laxatives, glycerin suppositories are definitely commonly used, but not strongly evidence based. At the end of the day, choice is individualized. So what I was trying to emphasize upon, the individual himself over a period of time manages his or her own bowel program. So bowel programs, structured bowel care with regular routine, digital stimulation, dietary fiber, rectal agents shows few quality trials, high quality trials, but it's still not of strong consensus and clinical benefit. Surgical approaches recommended only in selected and refractory patients. But again, as I mentioned earlier, given the choice, if it was a refractory thing, I would have definitely gone for a colostomy. Just before I move to the next slide, do you have any idea, like, if it is a colostomy, where would be the best place for a stoma and why? So it would be the sigmoid colon. Why? Because it runs through the whole colon, reaches there, it's a formed stool, and the chances of dehydration is much less than the rest of the colon. Again, the electrical and the neuromodulation therapies, stimulations, some evidence in incomplete SCI, still considered experimental. So these are actually very fancy names, this stimulation, that stimulation, but still there are very limited data on these sort of stimulation programs. This is a very important slide. whatever I was discussing has been mentioned by Cochrane in one slide. So if you look at this, it's 6 months here, 0 months here, and the movement or the patient improvement starts from 2 to 3 weeks. It keeps improving over time. So whatever we have discussed is basically from our side, it's just the guidance and the initial management. The patient actually makes or prepares his or her own bowel routine. So at the end of the day, it's restoring lives together through rehabilitation, technology, psychosocial support and medicine. But I would still favor, put my money on, let the patient himself or herself decide upon her own bowel management program. Thank you.
Thank you, Suparno. Open for questions, comments.
Thanks, Suparno. I agree with your last statement that not just for bowels, for any problem, the patient should be should take the primary responsibility. But so much more so in the case of bowels, because having a bowel accident in a public place is the most embarrassing thing, and so it's no wonder that some of them actually confine themselves to themselves without going out. So may I make one or two more small comments? What I found in India was that most people think that the rising of the sun or the rotation of the earth depends on whether they have a bowel movement that day. It doesn't. And when you say regular bowel movements, it doesn't mean daily bowel movements. It only means regular. Like you said, maybe only twice in a week it is necessary at times. So that's number one, that needs to be drilled into the counseling program. Otherwise, people think that unless they move their bowels every day, something really bad is going to happen. Number two, any bowel program that you start off takes about 3 to 4 weeks to bed in. Therefore, resist the temptation to keep cutting and changing and cutting and changing. Like what he said, it's a very bad practice to change management every day or every week, because you will never be able to get control of your bowel habits. Number three, what I have observed is that people who have, one of the good things about the West is that they have got good spinal cord injury management centers. Therefore, the patients come there for life. They have a very long-term perspective of what happens. And so I have actually come across loads of patients, young people who had the paralysis, managing their bowels excellently well. By the time they've done 35, 40 years of this, they notice that they are taking very much longer to do it. So some people actually spend 2 hours, 2.5 hours on the toilet. They're fed up with it.